thank you, Lyle, for joining us. Lyle Micheli here, and this is part of the ACSM, Distinguished Leaders in Sports Medicine and Exercise Science, and we're here to talk to Lyle a little bit about his career and his involvement with the college. So, could you sort of tell us where you're at? I know you're in Boston, and what you're doing.
I'm presently clinically active as the director of the Division of Sports Medicine at the Boston Children's Hospital. I'm the O'Donnell Family Professor of Orthopedic Sports Medicine at the Harvard Medical School. And our unit was founded in 1974. I was one of 4 founders. We saw about 90 patients that year, and now we see 300 patients a week.
Oh my heavens! Wow. And how many clinicians do you have in your group?
We now have 5 orthopedic surgeons and 8 primary care physicians, sports nutritionists, sports psychologists, athletic trainers, physician's assistants, exercise physiologists.
So was your training in pediatrics early on? And do you still, but you see all ages, don't you? Or do you just stick
primarily, we see primarily children, but I do see adults of our group. I still see adults because of my ongoing practice and the fact that I still see my old rugby buddies come in as patients and things like this. So I probably have about 20 to 25% adults, 75% children. I do 1,100 operations a year, and I see about 200 to 250 patients a week.
What kind of operations are you doing? Do you specialize?
Given my pediatric orthopedic background, I pretty much do the whole anatomy. I no longer do spine surgery. I used to do a lot of spine surgery, but I still see problems with back pain in the young athlete, and that's been one of our research interests. And but I see shoulder problems and elbow problems, little league elbow, and all that kind of stuff. And we've written a lot of articles about that stuff, and knees and ankles and hips and so forth. Yeah.
So, were you active in sports as a young guy?
Yeah, I just was inducted into the Athletic Hall of Fame of St. Bede Academy in Peru, Illinois.
I'll be darned. Wow.
And I played sports when I was there in Peru at the high school level. And then I went to Harvard and I played football for a few years, and then I boxed, and I played rugby for a long time. I played rugby for 30 years.
Oh, for heaven's sake. So this was, I know I was in Massachusetts a lot, and they have a lot of club teams and very active tournaments and weekends. And
yeah, rugby, we have a lot of rugby in Massachusetts now. We have 29 high school teams now.
Oh, that's,
which is opposed to, say, 10 years ago when we had maybe 4 or 5.
Yeah, I didn't know that.
This is true across the country.
It is.
To a greater or less extent. The rugby game is growing at the high school level. It's played as a spring sport. And with proper coaching, the injury rate's about the same as soccer, believe it or not.
That's fantastic. Yeah. Did you always have an interest in medicine? Or when did you sort of make that, or what did you major in as an undergrad?
Yeah. I was not really interested in medicine initially. My family background was pretty basic. My family were coal miners, and I think I was the first one in my family to go beyond high school. Yeah. I got a Harvard National Scholarship and a National Merit Scholarship. Went to Harvard. Was like going to Mars from Peru, Illinois.
Right, sure.
Worked construction that summer as usual. Got out to Harvard and I saw all these strange people. But yeah, I think that I gradually understood medicine near the end of my undergraduate. I majored in chemistry as an undergraduate.
Okay.
And then became more interested in medicine.
And then I think you just said it, but I was thinking ahead. You stayed at Harvard for medical school?
Went to Harvard Medical School.
Yeah, that's what
went to Harvard Medical School, and then at that time we all went in the military. So I was in the military for 2 years after my residency training at Harvard in orthopedics. And I went back as an attending at the Harvard Medical School at the Children's Hospital.
Okay. And were there sports medicine residencies then, Lyle, or how? No. Okay.
No, we think that our sports medicine program at Children's, we think it was the first sports medicine program in the country. We're looking at children.
Oh, yeah.
And so we think it's unique in that regard, and it still is one of the few in the country where they have fellowship training in pediatric sports medicine.
Do you know Steve Anderson? here in
Yes.
Seattle?
Mhm.
Okay, he comes in and speaks in my class.
Sure.
I mean, his point is that he's developed a whole practice in pediatric sports medicine that he never thought that would happen,
Yeah.
years ago.
We have our fellowship. We have 3 fellowships now, positions in orthopedic sports medicine for pediatrics, and 3 in primary care, and they're very sought after. I would say the past 5 years in particular, people are now, the children's hospitals across the country are now looking for people to do pediatric sports medicine. So our fellows have a good job market.
I've just noticed in the last, I think it's really been 2 years, Children's here in Seattle has been advertising their sports medicine clinic.
Yeah.
And I don't know how long it's been there, but this
That's
is the
probably
first
typical.
I've
Yeah.
heard about it.
Right, that's probably typical. It's been a recent phenomenon that children's hospitals have waked up and said, wait a second, why should we let all these kids go to the adult physicians in town when they have special kind of problems?
Yeah, I've noticed that shift just here. So I see you're wearing a FIMS
Right.
emblem. Have you been involved with the international group too?
Yes, I represent the American College of Sports Medicine and the Americas on the FIMS board. I'm the vice president for the Americas on the FIMS board. And previously I was chair of the Education Commission, and I've been involved with FIMS for probably 12, 15 years now, and nominated by the American College of Sports Medicine.
Oh, wonderful. Yeah, because, I mean, they started in the 1920s. And
probably the earliest sports medicine organization.
And ACSM started out as a chapter of FIMS with Joe Wolf and that group. But, so how did you get involved with the American College of Sports Medicine?
Well, a young lady came to my clinic. As I said early on, I did a lot of scoliosis and spinal surgery.
Yeah.
And so a young woman came to my clinic with scoliosis, and her father was named Skip Knutkin.
Oh, for heaven's sake. Yeah.
And so he was in our scoliosis clinic that day, and he happened to see in the back of our clinic a sign which said Sports Medicine Clinic, and he asked what that was, and I said that we're starting a new sports medicine program. It was about 1975.
Wow.
And he said, very interesting, and he said, you've heard of the American College of Sports Medicine? And I said, well, I'm not sure I have. And he told me all about it, and he basically got me involved in ACSM.
I didn't know that.
And thereafter, I got involved in the New England chapter, which was one of the early active regional chapters of ACSM, and then became president of ACSM or New England.
Oh, for the chapter
Yeah,
first.
for chapter.
Yeah, okay, sure.
And then I was nominated for the board, and then I moved up through the board of ACSM as a representative, and then as a vice president for medicine, and then as president.
Yeah, I was trying to think. I wrote it down. You were president in 90, I guess. Or
1989, 90.
89, 90.
Yeah.
And if I remember correctly, things were not going real well at the National Center in those days. I don't think we need to get into a lot of details, but
I had an interesting presidency.
I remember that. You had to make a few trips to Indianapolis.
I spent a lot of time in Indianapolis that year because the previous executive vice president had resigned, and so in the interim, we had an interim leader, and then we started a search, and I am proud to say that I was the one who offered Jim White the job at ACSM.
What a fantastic. Now, the interim was it Hubert Dagley, or was he the?
Yes.
Okay.
Well, Dagley was the one who resigned.
That's right, and I forgot.
And our CFO took over as
interim.
As interim,
Right.
Yeah.
Right.
And I was going out to Indianapolis every other week. Every other week, I'd drive on Friday and spend Saturday working in the office.
And Jim was with a medical group in D.C.,
He was with
wasn't
the
he?
Ear, Nose, and Throat
Yes,
National
that's right.
Association.
Yeah.
Yeah, and he was working there and had good experience with medical groups. And we liked him, and he was right at the top of our list, near the top of our list. And I was negotiating with another person, and that didn't go the way I thought it should go, so I offered the job to Jim.
Wow, and he took it, and the rest is history. He's been wonderful. I mean, you know, he's really been very good for the college.
I think so. I'm very pleased with him, and he's done a great job.
Was there an issue, Lyle, when you were president, or had we ironed that out yet, of sort of the 3 main groups and the constituents? And
That was a matter of debate while I was on the board. Right about the time we were debating moving to Indianapolis or staying in Wisconsin, and I was on the committee that did the site visits in Indianapolis, and it was so ironic because we were concerned about the dynamics of it at the time, and the city of Indianapolis had great leadership at that time.
Yes, Hudnut was the mayor.
Mayor Hudnut.
Yeah, yeah.
And they offered us matching mortgage and free land, but the thing that we didn't know about was the quality of the workers. Quality of the people who were going to work for us.
Oh, I hadn't heard about that. The who you're going to hire.
We were hiring people who were tremendous workers, good work ethic. Many of them had farming backgrounds, good old Midwesterners.
Yeah, hard workers.
Right.
And every time you talk to or Jim Whitehead or somebody, that staff keeps coming up. You know, what a great staff.
Yes, absolutely.
And some of them have been there for, I think 30, late 20, or 20-some years, some of them.
So we moved to Indianapolis in 79, 78,
yeah, I
79?
don't remember when it was,
yeah.
Lyle.
Oh, no, but absolutely. Some of the staff are still the same staff, but they've been wonderful to work with. Yeah.
Yeah. And as president-elect and president and all that, you've had your share of working with them as well. So what do you think, were you at the business meeting?
I didn't get to that. No.
Okay, because one of the issues, actually, it was brought up by a physician. I'm blanking on her name, from Philadelphia, past president.
Angela Smith.
Angela Smith stood up and said, you know, as a clinician, I'm concerned that we're getting so far in this social policy stuff that we're forgetting about the science, and I'm interested in the science and to help my practice and so forth. Do you have any feelings? You've been with the college a long time. Is that getting out of balance, or
I have a sense that may be the case, and I think that we have to write that because we have to maintain relevancy.
Yes.
Science without clinical relevance can go off in its own direction.
Absolutely.
So we have to keep the clinicians involved, and clinicians are under a lot of pressures now in their own practices, and so there are a lot of different competing organizations, but nonetheless, we have to come up with a strategy for maintaining physician participation and interest and activity. And by the way, I think it'd be a win-win situation.
Yes.
I believe this organization offers a tremendous amount to the practicing physician. You can go to this organization and you can sit in on a session on fat metabolism, the latest ideas in it. It really gets you back to the grounding, the scientific, where science is in certain these issues that we see every day.
Right.
The young female athlete who's getting stress fractures because she has a triad and so forth. I insist that my fellows, all 6 of them, come to these meetings, and the team physician course also. We pay their way to the team physician course because it gives them the broadness. I don't want them just to be an orthopedic surgeon who happens to do sports medicine and whittles on kids' elbows or shoulders.
The context.
I want them to know the whole context of the patient and every aspect of the patient and their family and so forth. But we must maintain the clinical activity and clinical interest. Some of the discussions devoid of clinical reality can become very off base. You know, to have one of my former patients, her interest is now in studying the ACL reconstruction, 2 different technologies for studying ACL reconstruction. Without input from real clinicians who do those surgeries, this could be an esoteric ivory tower effort. She's sitting off there at her university hypothesizing why it might or might not work when we see it every day.
Yeah, I understand.
So we have to maintain this rich mix. Under my era, and I would say to some extent under my leadership, I was a strong component of increasing the participation in the college of clinicians of fitness. There was a strong feeling at one point that an exercise physiologist was someone who had a PhD in exercise physiology or exercise sciences and practice at a high academic level. And we began to push for the participation in the American College of Sports Medicine of the clinicians of fitness, the master's level and the undergraduate level kids who are working in health clubs.
Yeah, and look what's happened.
Exactly. Exactly.
Yeah,
we are relevant to their proper practice also.
Absolutely.
They just can go off on their own, just as and we all can go off on our own little worlds unless we have maintained the active dialogue, which the ACSM provides.
Yes.
This is the format which we, and so rotation of the president. It was a hotly debated thing at the time, and whether there was a third track, either the didactic teachers and so forth, wasn't just another way of packaging the PhDs and. In the exercise science, and I don't think it is. I think that there's a whole group of people in that area that aren't really doing research in exercise science and so forth. But I think it's worked quite well. But we have to. It's something that won't necessarily happen. We have to keep after the different groups. We have to keep after the practitioners of fitness. We have to keep after the practitioners of sports medicine. And if a research scientist is studying this or that aspect of metabolism or metabolic response to exercise, doesn't realize that they really have to talk to the doctors who are treating these kids every day.
Why do it? You know, I mean, I think that's what they were. A couple people I talked to this morning, like Russ Pate, and we're talking about the social policy. Well, if we're not going to do something with what we do, why bother? You know, why do it?
Absolutely.
You know, we're trying to get this public health message out, or we're trying to get this information about ACL tears or whatever. So, you know, just...
No, I think the public service part of our mission is very important.
Yeah.
It isn't in any way in conflict with maintaining high science and high clinical activity.
They go hand in hand.
Right.
I mean, you would expect it to be based on good science.
Right. Has to be.
Yeah, so... Yeah, everybody I've talked to so far this morning has been in agreement, so I didn't think there was a problem, and I think the social policy thing just seems to be more visible at the moment. I don't see it as...
In and of its nature, it has to be
public. Exactly. We've got to get the politicians involved.
Right.
It's not a bad thing.
No.
So... So what, going back to your practice today, so do you then, do you do any teaching at Harvard then too?
Yeah. Our division is, we do patient care, teaching, research.
The whole bit.
And public service.
Okay.
We do a lot of patient care. As I said, we have
a lot.
Where we used to have 1 or 2 doctors, we now have 14, 16. And we have our own sports nutritionist. We can hire
are you in Cambridge then? Are you on campus?
No, we're in Boston. We're
in Boston
right
itself.
next to the medical school, which is in Boston.
That's nice.
Yeah.
Very
and
nice.
But we teach. We have medical students and other physicians and residents in training, rotating through our service for sometimes a month at a time. We teach our residents in training. They will come into my operations, and I'll teach them how to do the various techniques of care, and they'll come to our clinics and learn how we try to figure out why this girl has this leg pain on her right leg, and what is it, a stress fracture or a compartment syndrome. Or our diagnostic aspects are very important and very difficult sometimes. Totally different from mechanical orthopedics, where you see someone with an arthritic hip and you say, oh, you need total joint.
Yeah.
That's easy.
Yeah.
Okay. Our stuff is often very hard. So we fight to get our residents rotating with us, and it's an ongoing dynamic battle. And then research-wise, we have presently 47 research projects at our unit.
Wow.
Yeah. So
now, are a lot of these grants, or is it
about
self-funding, or how does that work?
It's about between a third and a half of them are actually external grant funding, and we have primarily foundations, companies, and some of it's internally. We have a foundation at Children's. We get internal small grants for our fellows. If they want to take on a project that involves $10,000 or $20,000, we can often get that internally from the hospital. But we want, at the end of their fellowship training, I want them to do at least 1 or hopefully 2 refereed articles, and then they do other research, other review.
And they're with you, what, 2 years, 3 years? 1 year, you did say
12
that.
months.
That's right. Wow, that's a busy. That's a busy year.
They see a lot of patients, and we're very proud of their activities. One of our primary care doctors is going to stay on with us, and he became interested in concussions, and at his behest, to a great extent, we started a concussion clinic about 9 months ago, sports concussion, and now it's standing room only.
Oh, wow.
It's a very underserved problem because
Where's Bob Cantu?
Bob
He's
Cantu
in
is,
town
well, of
too,
course,
isn't
he's dealing primarily with adults.
Oh,
He's an
I
adult,
keep forgetting that.
adult,
Yes, of
adult
course.
neurosurgeon.
Yeah,
Yeah,
that's right.
Yeah.
That's right.
yeah. But no, he's definitely, we participate with him. We put on a course each year with him.
Yeah.
But he's been very helpful and very supportive.
Yeah,
So
what a
we're interested
great
in
idea.
we're interested in the kids.
Yeah.
Kids with concussions.
Stan Herring was telling me about the law that our state here just passed.
Right.
Dealing with that.
Yes.
So,
Yeah. And that is a very good first move. The first one in the country.
I wondered if that was,
First in the country.
and it took a death, I guess. I don't know the details to spur the legislator.
I don't think the boy died, but he had
He
a very
did.
very severe brain injury.
Okay.
He had a second impact syndrome.
Yeah. So that whole return to play is
Yeah.
a giant issue.
Absolutely. And in all fairness, the average neurologist dealing with concussion doesn't usually have to deal with return to play.
Yeah. Good point.
They
Yeah.
basically
Not a-
treat the kid,
It's not
and
a factor.
then the next thing you know, the parents are saying, "Well, can she play in her soccer match this Friday?" And he says, "What?" You know, he just sort of said, "You have a concussion, you're going to have to wait," and so forth and so on. So, what we offer to the envelope is a sports medicine approach, which is when they can safely go back to play. And so, it's just amazing how rapidly that clinic has grown.
I have a colleague that in my department is called now Bioethics and Humanities, and we have a large group of people that do bioethics issues. And the sports medicine group came and asked if someone would come and talk to them, and one of our ethicists volunteered. Well, she knows nothing about sports.
Yeah.
And so we were talking a little bit, and she came back to me and said, "Jack," she says, "that is really a different group." And I said, "Yeah, they're talking about sports where people want to compete and win and so." And she goes, "Well, I'm not used to dealing with that kind of people, you know." So she's basically had to get educated
Yeah.
about athletics
Yeah.
and what
But
that's all about.
By the way, there are tremendous ethical questions in sports and sports medicine.
Oh, absolutely.
Tremendous.
Yes.
You know,
All the
when
time.
I get called by I'm taking care of the Boston Ballet, and I get called by the artistic director, who wants to know what's wrong with that dancer. And the dancer is my patient. I have nothing to do with him.
Exactly.
The dancer can tell him what's wrong with her.
Right.
But I'm not going to tell him and tell her what's her future in dance and so forth.
Yes.
I cannot do that.
Yes.
And the same thing with a team physician, say on a professional team.
Oh, my.
Can you imagine the pressures that the doctor's dealing with in that
I
situation?
haven't talked to Stan about it, but
Mhm.
I can imagine.
Yeah, yeah.
Yeah, your star.
Dollars.
Yeah, that isn't.
Yeah. And
Playing.
that in the area of concussion, think about that.
Oh, my.
This darn doctor's telling him that he can't play this weekend because he had a concussion. That's
Yeah.
just getting your bell rung, by the way. What's that?
Yeah.
Everybody gets that.
Yeah, yeah. Be a man, right?
Yeah, get out there and do
Shake it off.
Yeah, right. Shaking up on the play.
Yeah, exactly. Oh, gee. Yeah, it's scary.
No, so there's tremendous need for ethical considerations in sports medicine
Yeah.
and guidelines.
Yes. Yes.
And the kids.
Yeah.
I had a child 3 weeks ago, young gymnast, elbow injury, and I said, you know, I really don't think I think she should stay out for a minimum of 3 weeks. The kids are, and she had sectionals that weekend. The mother burst out crying.
Oh, boy. Yeah.
You think that it would be, at the very least, a neutral issue for her. I'm looking out for the well-being of her child.
Yeah, but it
she
isn't
was
for a
she
lot
was
of parents.
crushed that the kid couldn't compete that weekend.
Yeah, I've seen that many times where the parents are in it more than the kids.
Totally, and we did a program about that last week.
Mhm.
Yeah.
Wow. Now, I think back at, was Bergfield at Cleveland Clinic?
John Bergfeld.
Yeah.
John Bergfeld was, still is at the Cleveland Clinic.
Okay, because
Yeah.
I haven't seen him in a long time.
Yeah.
But, I mean, he was very active in the college, and I wondered if you guys were sort of doing the same thing at the same time.
He's more of an adult orthopedist. He didn't do the pediatrics part of it.
Yeah.
But he was a team doctor for many years for the Cleveland Browns.
Okay.
And got involved in all that type of stuff. And he certainly, the team physician course that we have here at the college
Yes, yes.
came out of a committee that I was chair of.
Okay.
The committee was, how should we get the clinicians involved
Yeah.
and do a clinical course in sports medicine. And we
Yeah.
had a meeting there, and everyone was arguing. Oded Barrow at the time thought it ought to be about physiology. And so I came up with the idea. I said, let's not call it sports medicine. Let's call it a team physician course.
Mm-hmm.
And we can define if someone's a pediatrician or if they're a pathologist or an orthopedist. There should be a body of knowledge they have to know.
The commonality is the team
Right.
physician
If
part.
you are
Yeah.
a team doctor,
Yeah, I see. That's a
whatever
good
your
idea.
background is, surgical or non-surgical or whatever,
Right,
you really should have a body of knowledge. The orthopedist must learn about concussions
right.
and nutrition.
You've got to know a little bit about all this.
Right, and so that worked tremendously, and that was the rest is history.
Yeah.
Our team physician course became
Is that
very
a
popular.
Two-part course?
Now it's a two-part course. Yeah.
Yeah, initially it was just one.
We
Has
started
it
out as
always
one, and then we went to three, actually.
Yeah.
We thought that was too much, and we put it back down to two.
Uh-huh.
Yeah. But I think that was one of my legacies, and I think that I'm very pleased to see how well it's done. And it's met a need.
Yeah, oh, definitely.
You know, there are some people who are not going to be full-time sports medicine doctors, but still are the team doctor for their community.
In whatever little town it may be.
They may be a
or-
pediatrician or an internist or an orthopedist,
Yeah.
and yet
sure.
we really want them to learn a certain body of knowledge to
Yeah.
be a team doctor.
Yeah. And then there's the guidelines that have come out, the team physician guidelines
Right.
and so forth. And
Yep.
were you involved in that too? Or I know Stan was.
I
but
was
that
not involved in that
a pretty
paper.
big committee.
Yeah, I was not involved in that paper. I was involved in the inception of the concept, the team
Of the
physician
team
course.
physician.
Yeah.
Was that just was that a weekend? Was it a 2-day intensive thing?
2.5
or
days.
2.5
days. 35 hours and 35 hours it came down to. Yeah.
Yeah, okay.
Yeah. A lot of work.
I know. So anyhow, we're just about out of time, but I told you 30 minutes would go real fast. So I was just wondering, looking at the big picture, if you still think ACSM's on the right track and
Well, I think
seems to be growing.
I think if we pursue excellence in every one of our sectors,
Yeah.
the science, the clinical medicine, the public service,
Mm-hmm.
and the public message, I think that it just will fall into place.
Yeah.
I guess the only concern I have, to some extent, is that we have to keep the clinicians, and particularly the orthopedic clinicians, who are often very busy, have a different lifestyle in some
Mhm.
ways, and particularly in present economic situations.
Yeah,
You know,
What's the other group that they would be in, Lyle?
the American Orthopedic Society for Sports Medicine.
Okay, and they have their own journal.
Yes,
Yeah.
but that is someone who's pretty much of a full-time sports medicine doctor,
Mm-hmm.
and that's about 800 members.
Okay.
Now, that means there's another 8,000 orthopedists
That are doing.
who are doing some to greater or less extent, doing some sports medicine, who I think would be ideal candidates for an organization such as ours,
Yes.
such as the American College of Sports Medicine.
Good point. Yeah.
Yeah.
Yeah. And have they been tapped, or is there any ongoing dialogue?
To be continued.
Next year, right?
That'll be one of our discussions with Jim over the next couple of days.
Good.
Yeah. Yeah.
Well, Lyle, thank you so much
Jack, glad to be here.
for stopping by and
Good.
talking, and this has been a lot of fun. I've been
Good.
anxious to talk to you. I tried to get you in New Orleans, and everyone was so busy down there, so I'm glad this
Yeah.
worked out.
Good.
So.
Glad to do it.